Welcome to Critical Conversations Trauma Unfiltered, where we dive deep into the world of trauma care, exploring the controversies, innovation, and life saving decisions made when seconds matter. I'm your host, Dr. Nirdosh Rasani, and today we are joined by Professor Karim, one of the world's leading voices in trauma, surgery, trauma systems, and critical care. Professor Karim is the professor of trauma sciences in the Blizzard Institute, Barts, and London School of Medicine and Dentistry, and consultant trauma and vascular surgeon at Barts Health NHS Trust. He is also director of Northeast London and Essex Trauma Network. Today, together, we will explore the cutting edge of trauma care from damage control strategies to future of trauma systems around the globe. Professor Karim, thank you for joining us. Trauma is the leading cause of death for young adults worldwide. Before we dive into the specifics, what excites you most about the evolution of trauma care today?
Thanks for inviting me, Nirdosh. Just to clarify, I'm not actually the director of the Northeast London and Essex Trauma Network anymore. I was for a time, a long time ago. Then I was the London Trauma System Director, but I stepped down from that after 10 years, a couple of months ago. So now I'm the director of nothing apart from the Centre of Trauma Sciences at Queen Mary. What excites me about trauma care? I think probably the same thing that has always excited me, that it's a very complex condition. It happens very acutely. We don't understand it very well. There's still huge amounts of improvement that are possible, both in terms of what we already know and doing better for each individual patient and leveling the playing field across regions, across countries, and then also understanding what we don't know and seeing how we can use research to improve our understanding of the human response to injury and then develop new pathways and new treatments for those.
Great. So we are opening the main discussion question, and I will be excited to ask you about the trauma systems and the global challenges. So, if I ask you, in your experience, what is the single most critical factor that determines whether trauma patient survives or not?
So I don't think there is a single most critical factor, to be honest. I think it's important that we understand that trauma patients are not one thing. They are different things based on their injuries, their background, and the healthcare setting that they are injured in. For a penetrating trauma patient who's bleeding out, the most critical thing is not the same as for a brain injured person. And for those people injured on the streets of London is very different from being injured in a very sort of rural setting, very different from being injured in a conflict setting. I think my main goal at the moment, is to ensure that we move away from very simplistic approaches to trauma care to really understanding that each patient may need something different. And then, of course, the systems of healthcare must be developed to understand those differences and then direct resources appropriately.
So, as you talked about that each patient is different and the settings are different. So, if I ask you, why do trauma mortality rates differ so much between the high income countries and the low resource countries, and how can you bridge the gap?
Yeah, so I think there are a number of factors there obviously at play. Number one, and possibly the most, or almost certainly the most critical, is the pre-hospital care systems that are available. The ability to identify somebody who's injured, get somebody to them quickly, if possible, do, immediate interventions that are required, but then bring them back to a hospital that has capability within, a reasonable time frame. So many healthcare systems around the world just lack that basic pre-hospital care element. And so many of the people who will survive to hospital, they're kind of already selected as survivors by the time they get there, and then care becomes more reconstructive. But I think to a certain extent, everybody experiences that. There's a difference between the person who is stabbed outside the doors of my hospital in London versus the person who has to be transferred an hour from, the outskirts of London or further beyond. There are elements of that, but it's always exacerbated with, if there's absolutely no pre-hospital care or those distances are prolonged. Beyond pre-hospital care, then survival depends on resources often, and that's things like the availability of blood, availability of intensive care, the availability of competent medical staff with the training. To be honest, most places I think have trainable staff, often very experienced trainable staff, but they're not able to deliver because of the resources that are available to them, or not able to deliver in the same way perhaps as standard teaching would say.
Okay. So you led the London Major Trauma System. So I would be excited to know what lessons can other countries like Pakistan, like Bangladesh, like India, or the other countries of South Asia can learn from building an effective trauma network.
Yeah. So I think, I mean, the things that we have learned over 10 years of building the trauma system, or 15 years now, have just been immense. But I think, some of the big lessons are to really come together as a regional system with multiple hospitals coming together to develop care for a population rather than hospitals, not warring, but, competing with each other for patients, or, wanting to say they're the biggest or they're the busiest, which is fundamentally not that helpful nor that useful. So one thing is certainly hospitals to come together to try and develop solutions that are equitable. There's usually a fair amount of expertise in each hospital, which is different from in the other hospitals, and that's a huge opportunity to learn from each other. That expertise can come together and produce pathways of care that are appropriate for your population. So, over time, for example, we produced guidelines in elderly care, pediatric care, procedures for CT imaging and things, and they're very London specific things. Obviously, they've been adapted for national use in other places, but it was very much the coming together of people in the region to produce pathways that were suitable for our patients. That was one of the really, I think, important things in developing a system that worked for the region. And then the other thing that is, how do you govern it? And for governance, you need data. It doesn't have to be great data. It doesn't have to contain everything, but you need to collect some data on who's being injured, what are the key things that you would like to achieve this year in terms of improving process, and how do you measure those, and how do you keep monitoring them. So I think if you have data and if you have the will for people to come together, those are probably the two biggest elements to develop a system.
So this message reminded me of the ATLS first chapter, in which the story of James Strainer is written, how he started to develop the ATLS. So I totally agree with you. So when there is a will, there is a way. Now, for the second segment, that's resuscitation and critical, as this podcast is seen by most of the ER physicians. So we will be dealing with this segment. So the first question is, damage control resuscitation has changed the trauma care worldwide. What are the core principles, and where do clinicians still go wrong?
So damage control resuscitation essentially was an extension of the original concept of damage control surgery, which was that you essentially match the surgery to the physiology of the patient. So you do as little as possible in order to save life. Damage control resuscitation then evolved out of that, which kind of has four main pillars. One is like definitive control of hemorrhage. So damage control resuscitation is with bleeding patients. If you're not bleeding, if you're not currently bleeding, actively bleeding, then damage control resuscitation is not for you. That's the first thing to mention. So if your patient is bleeding in front of you, then the four tenets are primarily early surgery to stop hemorrhage, and you may temporarily stop hemorrhage with tourniquets and things, but early surgery for hemorrhage control. And while you're achieving that, permissive hypotension, keep the blood pressure reasonably low to avoid increasing hemorrhage, and protecting the coagulation system by avoiding crystalloids, so avoid as far as possible giving clear fluids that will dilute the hemorrhage, and then identifying and treating any coagulopathy. So basic, that's tranexamic acid, but then giving blood products to manage coagulopathy. So those are the four tenets essentially: damage control surgery, hemorrhage control, keep the blood pressure reasonably low, avoid crystalloids, a clear fluid resuscitation, and correct coagulopathy with blood components or whatever you have available.
Okay. So as you just talk about tranexamic acid, TXA, a massive transfusion protocol, permissive hypotension specifically, how do you decide what to prioritize in the first 10 minutes of trauma resuscitation?
Yeah, so I think for us in London, certainly with the patients that come in to us, the first priority is bleeding. And that's catastrophic bleeding, people who are profoundly hypotensive or appear like they are transiently responding to fluids. So identifying people who are bleeding. And then secondarily, if they're not catastrophically bleeding or hypertensive, identifying those patients who may have a brain injury and managing their airway, and then thirdly, less common but other life-saving maneuvers like identifying tension hemothorax, that sort of thing. But the early search for physiological instability is the key, and then targeted treatments to those physiologies. But I think the important thing is that it's not going through rote protocols of I'm going to do A and then I'm going to do B and then I'm going to do C. You're actively looking for things that might be killing the patient urgently, and then you're actively acting on those findings. You're not just going on to the next step in a sort of standard. I think you asked me a question which I didn't answer, which was what's the mistake that most people make? I'm not sure I would call it a mistake necessarily, but I think it can be very difficult to identify people who are bleeding, especially in the early phases. So keeping your mind open that people, may still be bleeding, contained noncompressible hemorrhage, torso hemorrhage, pelvic hemorrhage. They may have responded a little bit to whatever fluid you gave them, but they are continuing to bleed and they are compensating for that until suddenly they drop their pressure and things. So, it's very easy once you're in damage control. It's not very easy. It's relatively easy once you're in a damage control setting mindset to do damage control resuscitation. Actually getting into that mindset can be the hard.
Okay, so people are talking about Reba a lot. So I'll be asking about the Reba. The Reba has been called a game changer for the non-compressible hemorrhage. Do you think it's ready for widespread use, or is it still a selective tool?
So I don't think Reba is suitable for anywhere outside of a few small institutions that have a specific program of research which is geared up at improving the delivery of Reba. At the moment, it's such a complex intervention that is used so rarely in most hospitals that its ultimate effect is just to delay hemorrhage control. And that's what we found from the UK Reba study. That's not to denigrate Reba, because it, ultimately we need a solution or a set of solutions for non-compressible hemorrhage, and we don't have them at all, really. And so Reba was, the first in a suite of those. Unfortunately, it takes too long to deliver, if you can deliver it, even in the people who are in extremis. B, it creates such a big zone of ischemia that you can't keep the balloon up for very long. Now, there are things hopefully coming down the track in terms of partial Reba and possibly other methods for controlling non-compressible torso hemorrhage. But at the moment, I don't think anyone can hand on heart say that it should be taken up by hospitals as an effective method of hemorrhage control.
So I just want to add here that as the fresh graduates or the new residents in the ER or the trauma surgery or the general surgery, so if I talk about specifically a drama that's a good doctor series, it's a series basically. So I was amazed to see that the doctor works in a tertiary care hospital, and then he gets a patient who has some leg trauma, long bone fracture, and he's bleeding a lot, and then he tried a Reba. So the people, the fresh graduates specifically, they follow these kind of the trends, and they ask a lot about the Reba. So to me, as far as I know, that if you have you work in a tertiary care hospital, there's a facility of 24/7 working, think that this makes sense in 21st century. What do you say about it?
So I think if you can get these patients to the operating room quickly, that's better than temporizing. I think the question is, if you've got people who are literally exsanguinating in front of you, or, go into peri-arrest in front of you, you're not going to get them into the operating room. And then people are searching for a solution. Again, Reba really, it takes time to get in unless you're slick at it and you do it long enough. I think, most extremity injuries, what you want to do is put a tourniquet on. That's your temporary hemostatic solution for a leg injury. Groin injury, maybe, and certainly Reba has found some use in, infected pseudoaneurysms of the groin that blow out, where surgery can be extremely difficult. And Reba has found solutions in other bleeding conditions, like placenta accreta and things where it's put in semi-electively potentially. But for an extremity leg wound, if you're looking to temporize hemorrhage control, it's tourniquet is your first point.
Now we will be talking about trauma surgery and decision making. So when managing complex polytrauma patients, how do you balance aggressive intervention with staged damage control surgery?
So I think damage control surgery is an aggressive intervention. I think to do good damage control surgery, you really have to properly go for it. So it's certainly not, it's certainly full on surgery. So if you mean rather, when do you do stage surgery versus when do you do a full operation, reanastomosing bowel and that sort of thing. I think you can put everything back together if you're content, that the patient is well perfused when you do it. So not only are their blood pressure and things normal, but their basic cess and lactate are normal. They've got warm extremities such that they've got good blood flow to the gut, that sort of thing. If you think that you have definitively identified all injuries, and you don't need to go back in, and let's say you're worried about potentially a pancreatic injury, which can be difficult to identify in the first look, that sort of thing. If you're convinced that you have debrided sufficient tissue such that the tissues that you are sewing back together again are good enough that they will hold. And if you believe that the patient is not going to go through a period where they become worse for whatever reason, or end up requiring high doses of pressors and things, such that whatever you do to them may do worse. Mostly, I'm very fond of doing staged surgery. I think it allows you to really assess what you've done, especially after, a big bleeding case or something. But even someone where the anatomy has not been clear, you're not entirely sure what you debride, you're not entirely sure if you've taken enough gut back, you're not entirely sure what the perfusion is. I will leave the ends of bowel stapled off, just put packs down to a possible pancreatic injury, that sort of thing. Just close the skin and then come back the next day and have a look, or when appropriate, but when the patient is warm and well perfused, and you've got to can have a look at the injuries in a much calmer setting with less contamination from the first operation. So, and there's very little to lose from that, especially if you're closing skin, I think. It's not too complex compared to, managing open abdomens and things. So I almost always close skin for a stage procedure, not sheath, and then we'll bring people back. And I'm very liberal in.
Great. So there's a very exciting, if you say it's a topic or it's a component of emergency medicine, critical care as well, and trauma, the cognitive biases. So in trauma-based worldwide, human error and cognitive biases can kill. What are the most common decision-making traps you have seen?
So I think a bit like we were talking earlier with doing damage control resuscitation, the first thing is not realizing that the patient in front of you fits a particular pathway. We often talk about so-and-so's massive transfusion pathway didn't go so well, or they should have had this brain injury protocol. But if you don't realize that people have a brain injury, or if you don't realize that people are bleeding, then if you start to go down the wrong track, or if somebody tells you that the patient has this and it turns out they don't, it's very difficult to change course. And it's very difficult to change speed, actually, of care as well. So if you believe that a patient is not bleeding and then it turns out they are, it's very difficult to change speed, very difficult for a whole team to change speed. So first thing is thinking that you're doing the right thing when actually it may be something else. The second thing is, trying to treat things that are much, much rarer than the thing that is the most likely thing that is killing the patient. So again, somebody comes in with a low blood pressure, 95 times out of 100, that's because they're bleeding. Now, there are possibilities of spinal cord injury. There are possibilities of neurogenic hypotension. But A, they're much, much less likely. And B, if you treat those things instead of bleeding, you will do the patient a disservice. Whereas the same is not true the other way around. So I think one is, looking for rarities and getting stuck in those rarities. And then the third thing, I think, is actually failure to make a decision. Just trying to go through the motions and, reassessing and just not making a decision to do something, hiding behind diagnostic tests or imaging rather than making a decision. And making a decision can be very hard. And so you have to practice making decisions.
Okay, so if we talk about the training, research, and the future, the trauma training has shifted towards simulation. And the hospital where I worked kind of covers the trauma simulation and cadaver labs and hybrid model, if we talk about that. What skills should the next generation of trauma resuscitationists master first?
So I think all of these techniques are valuable. For the key, I still think, is pattern recognition, identifying people who are sick, And that can be subtle. So, the more people that you see, even the more people who are not sick, allows you to identify people who are sick and watch what way they're sick. Identifying how physiology responds to treatment, and then decision making. Decision making is like the adage about, no plan survives first contact with the enemy, or all plans are useless, but planning is vital. So in terms of decision making, that's understand that there is a decision to be made, but that decision might be wrong. And then there are contingency decisions. So in your head, you will have I'm going to try this. If that doesn't work, I'm going to try this. If that doesn't work, I'm going to try that. And so there are a number of contingencies, and that goes, whether you're trying to resuscitate the patient, or whether you're trying to, stop a liver bleeding surgically. There are stepwise decisions, or a whole tree of decisions and get out techniques that you can use, but you have to know those, and you have to know those already. And you can work those out in your head or by talking them through with experienced colleagues, but to actually think about those decisions before you have a patient in front of you.
So essentially, you are talking about the experience, basically the exposure of the trauma patient. As much you see, you were able to get that mastery over decision making. And
some of it is experience, but some of it also is thinking about what you are seeing. People always talk about, well, I need to see 20 liver cases, or I need to see 30 open chests or something. But actually, it's how much do you take from each individual case? How much do you think through the decisions? And then, you can do it dry. You can sit with each other and go, okay, we have a patient comes in. He's got a bleeding abdomen. I open his belly. He's got a belly full of blood. I suck out the blood and I pack the belly, but he's still bleeding. Now what do I do? Okay, I think he might have a retroperitoneal bleeding. I'm going to cross-clamp the aorta. Okay, you cross-clamp the aorta, but he's still bleeding. Now what do you do? Okay, well then I think it's probably caval or retrohepatic bleeding. So I'm going to assess for caval bleeding and then potentially pack down the liver or whatever. So there is a stepwise thing, and you can do that for everything, a pelvis injury or a spleen injury things. There are stepwise things, and you can talk through these things and understand what is the right next step and what would you try next. And you don't need any patient for that.
So looking forward 10 years, how do you see AI that's most discussed in the medical groups and the medical field? The AI, the telemedicine, and the global trauma networks transforming the outcomes of the trauma patients.
Yeah. So I think, one thing that AI, technology, telemedicine has the ability to do is level the playing field between people who have expertise and people who have less expertise. So, the ability to provide some sort of decision support for people, I think will be probably the main way that AI helps clinicians in the future, not just in trauma care, but I think especially in trauma care, because you don't have the ability to reach out to people and discuss cases in the same way as things that are less time critical. So I think having AI-based decision support will be one of the biggest ways where it can help. And whether that's, something complex like taking real-time data feeds from patients and providing parallel decision support, or whether you can give it basic information and it can give you a list of probabilities of what's most likely to happen, or a list of possible get-outs. I think that having a AI beside you, not replacing your decisions, not doing the work for you, but giving you a little bit of support in terms of, okay, you're doing this, that seems like the most probable thing that's going on. There are these other two possibilities in the background. What's the response to giving a litre of crystalloid or 2 units of blood? If the response is this, then it likely means that they are bleeding, or they have bled and they're not bleeding. Just so that people who are less comfortable with trauma, people who are more junior, may still display some level of that expertise as having the actual expert in the room. Yeah. So I think the biggest opportunity for AI in trauma care is at the clinical level, is in decision support, where it allows you to level the playing field between the experts who can do the pattern matching, who can do the decision making, and people who are less comfortable or less experienced with trauma care. So it can provide an extra level of support, and that might be requiring some complex system with multiple inputs of data streams, or it could be something relatively simple where basic information is fed into it on the fly, and it gives some level of decision support. But I think those sort of things will give people confidence to act while not taking over care from actual clinicians who are delivering it.
So now we have a segment that's called rapid fire bonus questions. So this will be a rapid fire. So first question is, what is the most overused intervention in trauma?
Ultrasound.
So ultrasound is the most overused intervention in the trauma as per Professor Karim. If you could change one thing about ATLS tomorrow, what would it be?
I wouldn't change anything about ATLS tomorrow, because ATLS has
Okay.
to be something for the entire world, and it has to change slowly and gracefully to look after everyone.
Okay.
So I wouldn't change anything about ATLS.
Great. So what's the most preventable cause of trauma that you still see today?
Bleeding.
Did you get the question?
Yeah, I said bleeding.
Okay, bleeding. Okay, so next, this is the segment which I like the most. This is the myths and myth busting. So the first myth today is more IV fluids is equal to better resuscitation.
Yeah. No, so I think we've learned for a long time now that the more certainly clear fluids that you give to a patient, the more dilute their clotting factors they become, the colder they become, the more acidotic they become, and the more likely they are to die either acutely or later on ICU of acute lung injury, brain swelling, abdominal compartment syndrome. So certainly not no fluids, but less fluids. Ideally, those fluids should be blood products, something that approaches whole blood, plasma, that sort of thing, but certainly not fluids with no coagulation factors in them.
Great. So the conclusion of this myth is that we are busting it with modern resuscitation prioritize blood products and permissive hypertension until bleeding is controlled. So the second myth is TXA, famously known as TXA, works for all trauma patients.
For all patients who you think are bleeding, yes. If you don't think a patient is bleeding, then no.
So there are certain discussions where also about TXA, it's mentioned most of the time that early versus late TXA administration. Is there any difference?
Yes, I think it's clear that, well, it's reasonably clear that the body that is in a hypocoagulable state switches after a number of hours into a hypercoagulable state. And the benefits of giving clotting factor products like tranexamic acid, but TXA especially, after 3 hours are probably minimal and may cause harm. You should be giving TXA as early as possible. And I think if the 3 hour window is gone, then you should not be giving it, unless you're about to embark on, a semi-elective procedure, which might involve bleeding as a separate event.
Great. So the third myth is every trauma needs immediate full surgery.
No, well, I mean, most trauma cases don't need surgery, or they need some reconstructive surgery afterwards. Some cases need stage surgery. Some cases can have immediate definitive operation. Again, this is, I think, not treating everybody the same and understanding the principles of injury pathophysiology and treatment.
Again, I'll be talking about Reba. So the fourth myth today is Reba will save any exsanguinating patient.
I don't even think that's a myth anymore. I think everybody, the majority of the world, accepts that Reba, as it currently exists, is not an effective hemorrhage control tool for most cases and most hospitals.
ATLS guidelines. This is the myth 5 today. ATLS guidelines are always enough.
Yes, so I think ATLS it's a great course. It's done wonders. I think it's probably the beginning of a framework to which people should grow their knowledge of trauma care and trauma pathophysiology. So it's a starting point for an individual. It's not where you should be as a trauma team or a trauma hospital or a trauma system. It still forms the underpinning basis, but it's the basic level and not the be all and end all. Okay, so if I briefly summarize it, it's ATLS as a foundation, not a ceiling. Professor Karim, today we have covered everything from global trauma systems to the split-second decisions that save lives. If you could leave our listeners, trauma surgeons, emergency physicians, and critical care teams with one message about trauma care, what would it be? I think it would be spend some time understanding physiology and the pathophysiology of injury and work out how that matches to the patients that you see in front of you and the treatments that you give them. So begin as you go further into trauma care to step away from protocolizing care where you do this and then that, to understanding what's actually going on with the patient in front of you.
Thank you, listeners. Thank you for joining us on Critical Conversations, Trauma Unfiltered. If this episode inspired you or challenged the way you think about trauma, share it with your team, subscribe, and leave us a review. Until next time, stay sharp, stay decisive, and always fight for the survival first. And thank you, Professor Karim, for joining us and giving us around 40 minutes of your precious time talking about the trauma care. I believe that this could be a very little effort, but I think that through this podcast, through this talk, we will be able to change, or we would be able to spark the thinking process about the trauma care, specifically in low resource countries, and specifically in the residents, emergency residents, the general surgery residents, and the critical care fellows. Thank you so much.
Thank you.